All right, so good morning. At least for us in Nigeria, it's morning. For people in Liberia, we have people from about seven or eight African countries, and then two from outside the African continent register for this meeting. Over 600 people registered, so we are going to be having a really, really large room. And of course, we're discussing something very important, data. And I think that's where Africa has missed quite a bit in terms of the progress we needed to record in the livestock industry. We do quite a bit of things blindly. And today we are going to be emphasizing why data is important. The title of our today's meeting is Data-Driven Professional. Because at the end of the day, uh, doing things blindly won't make us look good in the global stage. And I'm pretty very happy that we have quite a lot of, we've been able to generate quite a lot of interest in today's meeting. We are going to be having three hub experts. We're going to be having a one health intelligence expert, worked quite a bit with FAO and still consulting for FAO. A prominent professor that we have, somebody we're extremely very proud of in the veterinary profession. And I can also proudly say he's a member of the Farm Alert Advisory Board, but not just an ordinary member. He's chairing our advisory board. He's going to be talking to us last in terms of data. I've seen the quality of his presentation, and I think you will love it. The second person we're also going to be engaging today, just a moment, uh, that's Dr. Zainab. Dr. Zainab, can you say a word? Let me be sure that you're good with us now. Dr. Zainab. Dr. Zainab. Okay, so we don't have her yet. So I think we're going to take her probably next. But we have Dr. Aminu. I'm going to be reading out Dr. Aminu's. It's going to be a lot more interactive today. I'm going to be reading out Dr. Aminu's profile shortly. And from the look of things, because of Dr. Zainab's uh, network, we might probably be starting from Dr. Aminu Shittu. Dr. Zainab, are you on now? It's your, it's your, okay. If it's not up. So I think Professor Fasina is here. I think it's a good thing we start with Professor Fasina, right? Professor Fasina, sir. Backend, can you please make him a co-host and then unmute? Okay, I think Dr. Zainab is back. Dr. Zainab, can you hear us?
Yeah, I can hear you
Okay,
loud and
fantastic.
clear.
Okay, okay. So your video is still not on.
But
So what we could do is just to allow you, but can you try attempt sharing your screen? Allow you share your screen, and then I can read out your profile, and then we can start with you just the way we have planned. So we will just excuse your video. Can you attempt sharing your screen?
yeah, sure, I'm trying to.
Very
I'm about
good.
to.
Fantastic. So while she's attempting to share her screen, let me welcome, I'm going to be acknowledging us after her presentation so that I can take my time to pick the people who are online. But again, Dr. Zainab, one
Can
of
you see me?
yes, it's coming up, Dr. Zainab. Dr. Zainab is one of our very best in the veterinary profession. Dr. Zainab is a veterinary public health expert and field epidemiologist with a dual master, two masters, and really very happy for you, Dr. Zainab, in public health and infectious disease. She's a field epidemiologist and a fellow of the Malaria Modeling Fellowship in Nigeria. Dr. Zainab is currently pursuing a PhD in epidemiology with research focused on malaria transmission modeling and gender dynamics. Dr. Zainab is also the founder of One Health Messenger. Those of you who are on LinkedIn, I think this is one of our most popular brainchild uh, because of the quality of content and also the style of writing. So she's the founder of One Health Messenger, a platform advancing public health and awareness and intersectoral collaboration in Nigeria. So she's currently working with the Nigerian Center for Disease Control and Prevention. People, please give it up to one of our very best, Dr. Zainab Dambazau, the founder and CEO for One Health Messenger in Nigeria, to take the next 20 minutes to tell us why data matters. Then, of course, we'll take Dr. Aminu next, and of course, Professor Fasina. Then we go into what we have today. I'll see you shortly. Dr. Zainab, over to you.
Good day, senior colleagues, and thank you for finding time to join this webinar. So today I want us to reflect on how we practice veterinary medicine in Nigeria, not just what we know, because we know a whole lot. And this is a conversation about evidence, about efficiency, and about relevance, and how data quietly determines all three. This is not about any sophisticated software. Just let me say that. And it is about how information moves or fails to move through our systems. The presentation will be guided by the following outline. We'll look at the core problem, we'll look at systems and priorities, we'll look at evidence and case studies, we'll look at action and implementation. Let's take the next 5 seconds to reflect as I begin with the core problem. Nigeria's veterinary sector generates data every single day in farms, in clinics, markets, abattoirs, laboratories, and surveillance systems. Yet, much of this data is not systematically captured. I didn't say it is not captured at all, but most is not systematically captured, analyzed, or used for decision making. And this gap is not dramatic alone. It is costly because it shapes how early we detect diseases, how well we respond, and how much trust we earn. Livestock contributes approximately 8% of Nigeria's GDP and supports millions of livelihoods. Yet we continue to lose substantial economic value to largely preventable diseases because they are mostly preventable diseases. Diseases such as PPR, Pestidipestis ruminant, contagious bovine pneumonia, FMD, avian influenza, mastitis, brucellosis. In many cases, vaccines exist. Expertise exists. That one, there is no cap. What fails is timely information. And without reliable data, outbreaks are detected late, response is fragmented, and prevention becomes reactive instead of strategic. Moving to the next, and let me bring this directly to our practice. Without data, treatments are repeated without outcome tracking. We just keep on giving LA, albendazole. Are we really tracking the outcomes? Antimicrobials are used blindly. Early warning signs are missed, and clients lose confidence over time because they'll start jumping from one veterinary practitioner to another because of that loss of confidence. With data, our decisions improve. Follow-up becomes intentional. You follow up on your clients to know the outcomes. Costs reduce from both your own aspect and from the aspect of the client. And professional credibility strengthens. Data strengthens that professional credibility because with data, when you have data, nobody can do UC finish again. Data is not just paperwork. Data protects your practice. It protects your patients and it protects your profession. When you come to speak without data, people do not really know the impact of what you are seeing. To understand impact, we must see data as a system, not a form that we just sit out and fill. Client name, age, type of animal, the species, and all that. It's not just a form. So moving forward, let's look at it as a system. And the pathway is simple. If you just follow this flowchart, analysis supports timely decisions. Timely decisions improve animal health. Healthy animals protect public health and livelihood. If you break this chain at any point, outcomes suffer. Every case I'll share moving forward, I have a few case studies, follows this logic. If in our veterinary practice in Nigeria, we could focus on just 3 data streams in the near term. First, we look at our clinical and treatment records because outcomes and drug use matter. Secondly, let's look at our farm and production records because mortality, vaccination, and productivity drive livelihoods. People want to live, people want to survive, people want to be able to earn. Third, abattoir market surveillance data because zoonotic risks surface there first. Are we really looking deeply? These 3 streams give the fastest and widest returns. Data is not abstract. It is about our case logs and our lab results, our farm mortality, our vaccination records, market movements, abattoir condemnations, antimicrobial usage logs, and environmental signals influencing disease risks. We have this at our fingertips. And most of this data already exists. You don't have to go and look for it anyway. We already have it. What is missing is consistency, the linkage, and the use. Let us now ground this in the real practice, our experiences. Expert voices have noted some key phrases across the FAO, WOHA, the national veterinary systems. One lesson is consistent. Early detection depends more on data quality than on technology. The quality is important. You can have the technology without quality. So quality is very key, and Nigeria is no exception. Nigeria carries a high burden of PPR, particularly among small ruminants. And in several settings, reporting delays of about 1 to 2 weeks have been documented, often attributed to incomplete vaccination records, delayed field reporting, fragmented data flow between local and state levels. In contrast, you have digital pilot initiatives in states such as Kano, Kaduna, were associated with notable improvements in reporting timelines. In some cases, the speed could actually increase to about 30%. The lesson here is not technology. It's not about I have this technology, it's about speed. Because when data moves faster, containment starts earlier and losses reduce. During the 2023 anthrax outbreak, one challenge stood out. Animal and human health data were not immediately aligned. So if you remember where coordination lagged, risk communication slowed. I told us, let's look at it as a system, not as a form that I am filling my form in my clinic. No, look at it as a system. It's a One Health system. Where data streams converged, response was faster and clearer. We saw that in some states. And this was not a laboratory problem. It was a data flow problem because of those constraints. In many urban clinics, records remain paper-based. We all know that. The result is often repeated drug courses with no structured outcome monitoring. Clinic-level digital pilots in cities like Lagos and Abuja have reported substantial reduction in drug wastages, sometimes ranging between 20 to 40% according to literature, alongside better follow-up and improved revenue stability. If you look at the clinics operating in Lagos and Kaduna, we'll see that they're really doing well. That means they're really doing something right. and it's what they're doing right is data. Here, data directly improved both care quality and business sustainability. Antimicrobial resistance, which is a growing concern, and we've been hitting all the drums, oh, World AMRD, oh, World this day. But studies in Nigeria show that 50 to 70% of poultry farms administer antimicrobials without prescription, with heavy reliance on even tetracyclines. And without usage logs, stewardship cannot function. I can't say I'm an antimicrobial steward without any data. AMR is not a microbiology issue. It is a record-keeping issue. Moving to mortality in poultry surveillance. When you track that, mortality tracking in poultry systems has shown that early increases in deaths often precede major outbreaks. When mortality data is captured consistently, response can begin before escalation. That is why our data is important. Looking at pastoralists, we know the system we live in, and they move across ecological zones. They both carrying both livelihood and risk because they move diseases. Are we tracking them? How well are we tracking them? Where is the data for tracking them? Do I have, if I check online, would I be able to get that? If I look for that immediately, is this something that is on our fingertips? So, but pilot projects integrating movement data with outbreak reports have demonstrated marked improvements in predictive capacity. That's why prediction is important. And sometimes it exceeds about 50% because mobility plus disease data equals early warning. Data is very important. In our abattoirs, there are silent surveillance points. In urban centers like Lagos, several thousands of cattle are processed daily. Yet, only a minority of abattoirs maintain consistent records. There are records, but how consistent are our records? Where condemnation has been analyzed, such as brucellosis monitoring in Kano, there is a published paper. It has directly informed local risk warnings. When I was conducting my fellowship research, I worked in the abattoir. I took samples from slaughtered cattle, and everything was positive. And that paper is going to be published soon. Animal data feeds early detection of diseases such as Rift Valley, Lassa fever, Mpox, and other foodborne hazards. So if we have joint teams now operating, because data connects sectors, what is bringing One Health together is about data. How can we share data? How do we know what each sector, what is happening? How can we come together? How can we be a team? This is One Health in practice. It's data that is bringing us together. And I pray it brings us together better. Moving to action and implementation. So what can be done now? Clinics start with simple structured records. If we have our monthly case and drug reviews, if you have visual summaries for farmers, do not ignore the farmers. You can make it as simple as possible in whatever language you want to. It's not about English. Our low-cost tools already exist. Nobody is telling you to go and develop a tool because data culture is built. It is not bought. If you have your house list that you follow through the year, you can see the increase in your purchases. You train your support staff, simple trainings. You celebrate their small wins. If they take a whole month capturing the data, you have your data ready for analysis. Make your data routine, not exceptional. At this point, the question usually becomes, what can I realistically do within my own practice, whether I operate in the clinic or the abattoir? So let's use the clinic, for instance. So let me be very practical. These are not aspirational ideas. They are wins that clinics across Nigeria can implement immediately without waiting for national platforms. First, you can have your digital patient registers. Even a basic digital register helps you to see pattern, repeat cases, outcomes, seasonality. That memory alone cannot capture. Memory alone cannot capture this. It can be just on an Excel sheet. Second, you track outcomes, not just treatments. It is not enough to know what drug was given. What matters is whether the animal recovered, relapsed, or returned. Are we tracking this? Please confirm you can still hear me. Hello?
Yes, we can, Doc. Loud and
Yeah,
clear.
check-in call.
Yeah.
When you monitor vaccine coverage, especially for priority diseases like rabies, Newcastle, IBD, PPR, coverage data tells you where protection is thin before an outbreak appears. That's why we do a lot of modeling, and you see all these things on maps, and you project, you predict. Fourth, log drug usage monthly. This is one of the simplest steps towards antimicrobial stewardship and cost control. And finally, when you use simple dashboards quarterly, even if it is just one-page summary, but it is consistent, use it. Because good decisions are rarely made from raw registers. They are made from summaries. Now, people assume that data systems must be expensive. I mentioned this earlier. That is not true. Nigeria already uses many low-cost preventive tools. I give an example use of Excel. You have Google Forms that can support routine reporting. You have your Kobo Collect, and many of us are already familiar to many field teams. It works offline. It's something that immediately somebody can just train you on that. Excel templates, they are sufficient for tracking AMR and drug use in clinics. Your QGIS allows basic disease mapping without licensing costs. You have R, the statistical software. And in pastoral systems, even solar-powered tablets, as piloted by the International Livestock Research Institute and partners, show that power and connectivity constraints are not insurmountable. There is a solution. So the message here is simple. The barrier is really technology. It is adoption and routine use. If you have the technology and you're not adopting it, it's just dead on arrival. Of course, we must be honest about our context. Most clinics still rely on paper-based records. Internet access remains limited in many rural areas and very, very unstable in urban areas. I've been praying that mine shouldn't get unstable during this presentation until we're done with the webinar. Adoption of improved digital use tools is uneven. You can find 10 clinics in a state, but they're not even speaking to each other. So they're not even adopting the approved digital tools within the same state. And probably it's someone in the state that developed it. I remember during, I think, the last conference, someone introduced a digital tool. How many people have been using it? And data is still undervalued as a core infrastructure in veterinary practice. We are taking it for granted, but barrier equals to opportunities. For instance, the ongoing digitization of the NADIS and the growing One Health coordination shows that the momentum still exists. The challenge is alignment, is not absence of effort, but we need to align and we need to put our hearts together. Culture change does not start with policy, it starts with routine. And to build a data culture, make data routine, not exceptional. This is the second time I'm mentioning this. Train support staff, assistants, and technicians, not just veterinarians. Hold your monthly review meetings, even if it's brief. Share simple visual summaries with farmers. Transparency builds trust. You can't go to the rigor and say, oh, we want data on this, movement on that, and you do not give feedback. There's no feedback loop. So transparency builds trust. And importantly, celebrate small wins. People love to be celebrated for their efforts. When people see data, that data improves decisions, resistance feeds naturally. Even if they don't like you, they will like your data. Let me close with this. Data is not just paperwork. It is diagnosis, it is prevention, it is profitability, and it is public protection. When veterinarians use data, outbreaks decrease, AMR declines, farms become more resilient, public health is strengthened, and profession gains influence. Data is the backbone of veterinary medicine. These are my references. I have a little poem for you, The Habit of Change. Culture does not change with memos sent or policies signed with good intent. It shifts in habits day by day, in what we do, not what we say. A note taken, a record kept, a meeting held, a promise met. Routine turns effort into care, and that's how change begins right there. Thank you very much for listening.
Dr. Zainab, I don't know, you're all of a sudden becoming one of my best speakers, right? Your voice is, you know, you will want to change after listening to Dr. Zainab. Your message is simple. Your presentations are very thoughtful. And I muted myself, but alone, I was just saying, because most of your words are things that we should pick up and put on our walls if we truly want to change this profession. Let me thank you, Dr. Zainab. Please don't go. I believe there are quite a bit of some questions for you. We have 1 hour interactions after this. Uh, when all the hub experts have made their presentation, but it was brilliant. And some of those things, I think, I have the habits of repeating things I want to learn. I wish we can ask you to represent again so that we can listen again, because hearing those words wouldn't be too much. Yeah. So let me thank you, but please hang on and let's take our next hub experts. I believe we're finding.
I'll just stop sharing.
Okay, all right, good. Thank you so much, Dr. Zainab. Uh, so our next hub expert, who will take another 20 minutes, is Dr. Aminu Shittu. Dr. Aminu Shittu, please back end if you can help me spotlight him. He's a veterinarian, also an epidemiologist. Right. Because we're talking about data here. A public health researcher at the Faculty of Veterinary Medicine, University of Usmanu Danfodiyo University, Sokoto. His academic and professional journey spans veterinary medicine, infectious disease control, and One Health, supported by advanced training from the University of Edinburgh, the Royal Veterinary College, and London School of Hygiene and Tropical Medicine. Dr. Shittu is recognized for his contribution to quantitative epidemiology, antimicrobial resistance surveillance, UDA health research, and zoonotic disease epidemiology. As a senior collaborator with the Institute for Health Metrics and Evaluation's Global Burden of Disease Study, University of Washington, he plays an active role in shaping global understanding of infectious disease patterns and health risks across population. He has an extensive scholarly footprint with research outputs that are frequently used, widely referenced, and respected across multiple subfields of veterinary and public health science. His work not only advances scientific knowledge, but also strengthens evidence-based decision-making in animal health and food safety and disease prevention, of course. Beyond academia, Dr. Shittu provides mentorship to undergraduates, postgraduate researchers, lead multinational collaborative initiative, and contributes to capacity building across Africa through networks such as the Afri-Science Network. And by the way, the Afri-Science Network has membership of over 9,000. 9,000. So you can imagine that level of impact. His career reflects a deep commitment to bridging scientific inquiries with practical solutions that improve livestock health and community well-being. Today, he joins us to share insights on practical tools and approaches for effective data collection in veterinary medicine, an area in which his expertise and experience continue to offer valuable guidance to professionals, researchers, and policy makers alike. Ladies and gentlemen, please join me welcome Dr. Shittu Aminu as he makes his presentation.
Okay. Thank you so much. Thank you very much, Dr. Femi Kaide from Alat. Thank you, Professor Fasina, Dr. Zainab, and all the other people around today. I hope you can see my slides.
We can see your slide, but if we can also, can you enable your video so that we can spotlight you and you can come up?
Okay.
Thank you.
All right. Thank you so much. And let me confirm that the slides are moving, right?
Yes, they are moving. Fantastic.
Okay. Okay. So I've already been introduced by Dr. Femi, and this morning I'm going to talk about tools and approaches for effective data collection under this major theme of data-driven professionals harnessing insights for healthier herds. So I'm from the Quantitative Epidemiology and Animal Health Research Group in the Faculty of Veterinary Medicine, Usmanu of the University, Sokoto. So first of all, let me begin by asking question why data collection matters. We need focus on data collection because if there is no data, there is no any insight. You are not going to say anything but maybe personal opinions that may be wrong, but we need data, we need numbers, something that we can quantify. And poor data means poor decision. And then if you have a high quality data, your disease prevention strategy can be effective. You can prepare for emergencies, and you can boost livestock productivity with a good quality data. So specifically for livestock systems, early break detection using data-driven evidence-based vaccination planning. Data can enable you to design that. And with data, you can monitor animal productivity, such as milk production, egg production, and animal welfare. Rational use of antimicrobials on farm, and also what we call risk-based surveillance. So even the so-called analytical platforms, data analytical software, and the artificial insemination, AI, artificial intelligence tools, they depend entirely on data that is collected, a real-world data set. So if there is no data, or if the information you provided, you will get a wrong output. So that is based on garbage in, garbage out principle. So in this photographs, I summarize everything by saying that if your foundation is very weak, and then the wall is going to crack. So, and your foundation is data, and not just data, but good data, excellent data if possible. And so what do we mean by data in animal health? You can collect different type of data related to animal health research, demographic data. These are individual animal data, such as the age of the animal. Well, I'm working on cow welfare and other health, so I'm biased to giving examples.
All right. So I think his network, right? Okay, you're back, Doc.
Okay, where was I? Where did you miss me? At what point?
No, we just missed you. It wasn't even up to 5 seconds.
Oh, okay. So we can collect data at animal level, such as demographic data like age, sex, breed, heart size, etc. And we can collect data on health status of the animal, disease, clinical signs and symptoms, the type of treatment provided, and mortality records, production data, milk yield, growth rate of animals, and also the fertility. These are all production data, including egg production in poultry. And management data include the type of housing, feeding, and biosecurity provided, and also environmental data such as season, climate, and location of the farm facility, and movement data such as market to slaughterhouse, or movement between the farms or from farms to the slaughterhouse. So all of this information can help us in planning for disease control or whatever we are interested in. The reason why management data is important is because of the impact of so many management variables on the animal welfare. For example, this is one of the variables that we also have in our data set for the assessment of cattle welfare, which we are currently working on. We started working on that for the past 3 years, during the last 3 years, and we have assessed the welfare of over 3,000 cows, and we have over 45 variables in that data set. And I can tell you that each and every variable in that data set is important as far the welfare of cow is concerned. And for the climate data here, we know that many climatic variables have impact on the level of the disease, the prevalence of the disease, for example. So not only data, not only laboratory results are data. This is the argument that we tend to have with our colleagues in the lab, that are saying that they are the ones that are always doing the work, but you can do a PhD on a single slaughterhouse. Especially, I give an example with the slaughterhouse, because on a slaughterhouse, the population of animals is dynamic. It changes on daily basis, so you can see a lot of variations even on a daily basis. So farm records are data as well. Slaughterhouse records are data. And so some of the sources of livestock data, I listed them here. You can get your data from farms, commercial farms and smallholder, or from the pastoralist. You can generate data from the veterinary clinic and hospitals. I wrote a proposal on, I said I'm interested in looking at the outcome of all the dogs, female dogs that underwent cesarean section in Nigerian small animal clinics and hospitals during the last 30 years, if that is possible. But there is that proposal because we want to get some information out of that. I have mentioned earlier that you can get data from slaughterhouses and markets through field surveillance and outbreak investigation, through extension services, research studies that have been published already. There are data themselves especially for researchers that are doing systematic reviews and meta-analysis. You can get data from government and regulatory agencies, from industry and private sectors, maybe like pharmaceuticals and feed industries, and also from international and regional databases like FAO, WOA, WHO, etc. So in low and middle income countries, we have a lot of data. Data is sitting just there, and Dr. Zainab Dambazau rightly mentioned that. We have a lot of data, unless if you don't care to look for them. So it is either the data is not documented or they are underutilized. And here are some of the publications. Well, these two are based from in Great Britain and in Netherlands, and I only added them here to show you that farm can serve as a source of data. But the rest of publications here from our research group were consisted of data collected from Nigeria and Rwanda, and using field investigations, and some of them complemented with laboratory investigations, some not. And they were all published in top journals, good journals, and good statistical analysis. And so it it just depends on your initiatives and the quality of data. And so there are various data collection tools. Here are the conventional tools, such as paper-based farm records, as we were doing, as we started in the past. Well, we are still doing that. Logbooks and notebooks from the lab, from the slaughterhouse and clinics, registered at questionnaire. We published a study on knowledge, attitude, and perception of mpox, monkeypox, among stakeholders in Nigeria, I think last 3 months. And that was a questionnaire-based study and also observation checklist. So traditional or paper-based records or conventional data collection tools have their own strength. They are strong in the sense that cost and many users are familiar with them. But their limitations is that they can easily be lost, entry errors, and poor aggregation. But paper collection tools are still useful. They still dominate and they still remain relevant, although they need some improvements. And for the digital data collection tools, we have the mobile phones and tablets. We have online survey forms, ODK. Dr. Zainab Dambazau also mentioned Kobo Toolbox and Google Forms. We use Google Forms, and my undergraduate students that graduated during the last 2-3 years, even last year, they use Google Forms, and even currently we are still using Google Forms in data collection. And there are specialized farm management software for recording milk production in farm, on farm, or egg production. And there are electronic veterinary records and GPS-enabled data capture, which allows you to locate or to record farm location using the GPS or longitude and latitude, the location of the farm. And so the advantages of digital collection tools is that they are real-time and they are very accurate, scalable, they are easy. You can analyze them very easily, and you can share them easily as well, and they are georeferenced. So you can track the source of information. And they are scalable and timeliness for outbreak response. And here is a hypothetical data set which I created. So it is not a real data. I created this last night for the purpose of this presentation. So this is a data for routine farm health check. So these variables are not exhaustive, but I'm just trying to tell you that data for routine farm health management should consist of the farmer ID, which is a unique identifier for each and every farm owner. The location of the farm, here I mentioned some of the local governments in Sokoto State, but you can use geographical location, the longitude and latitude for mapping studies, and also the herd size, number of animals on the farm. The animal ID here is the unique identifier for each cow, for each animal, the age of the animal, the sex, clinical signs, and suspected disease, date of onset of the disease, and the treatment outcome. And outcomes. So whether the animal died, recovered, or the animal has improved, or whether the treatment is still ongoing. And there are many approaches to data collection, and some of them include passive surveillance. So passive surveillance include routine reporting and submissions from the clinic to the laboratory, and also farmer complaints. And we have active surveillance, which includes field visits, targeted sampling, and outbreaks investigations, which saves times and lives. And we have here active surveillance enable us for the detection of outbreak at an early stage or early, but both of these approaches are complementary. And here I'm using this paper that we published, I think, 3 weeks ago in pathogens. This is a data that was collected through active surveillance, through visit at livestock markets in these states in Nigeria, this border state. Well, Plateau is not a border state, but we included Plateau there. So just as an example. And participatory and community-based data collection is also important. So we can use people as data sensors, farmer reporting systems. Community animal health workers can serve as data sensors, and also through participatory epidemiology and syndromic reporting. And you can see some of the livestock, some herdsmen here in East Africa using mobile devices in reporting any issue of concern with their livestock, either through mobile communication or through an app. I think this app was developed by ILRI, as Zainab mentioned, which is, I think, is commonly used by farmers in Tanzania or Kenya. And so the benefits of this data collection tools is that they enable early warning systems, and you can generate information about the local knowledge of disease of the disease or livestock production system, and there is trust and ownership as well. And in ensuring data quality, here are some of the key dimensions. Data has to be consistent, which means it should be recorded the same way across time and location, and also by same data collectors. And in terms of accuracy, data should reflect reality. Example, GPS coordinates, diagnosis of the disease and outcomes following treatment, they have to be real. And in terms of completeness, it should include all the essential variables that are needed, or all the covariates that are required in the data. Key fields within the data set. And for auditability, we should be able to identify who collected the data and when and where. So in case of any, in terms of orderliness, data should be well structured and logically arranged. In fact, whenever I see data that is ordered, honestly, I tend to be very happy, and it motivates me to start my data analysis without wasting any time. And in terms of uniqueness, we don't need duplicate records. So every entry, if you have a variable called sex, it should be the only one. I don't want to see another variable named sex within the data set, unless if they are fragmented data, which means something different. And that is what uniqueness is. And in terms of timeliness, data should be collected promptly, especially outbreak data where we want to take a decision immediately. So no late data collection. And in terms of validity, within the data, they should be everything should be acceptable. Everything should be within the acceptable range. So, for example, why should I have an age that is recorded with negatives? So, negative age, that is not valid. But some of the common problems that are associated with large data sets include missing values and inconsistent code and what we call recall bias. But for missing values, there's a way you can fill them up using imputation method. And so we are interested in high quality data. If data can be small, but of high quality, a small data set of high quality is better than a large data which is poor. And so in terms of standardization and data dictionaries, whenever I receive data for any analysis, I used to ask for data dictionary. Data dictionary is the second sheet within the Excel file that defines all the variables that are included in their dataset with their meaning. So if I see species in the dataset, variable, especially for statistical software that accept that use numbers in the analysis instead of text or string variables. Standardization matters because all the variables they need to be harmonized. So for example, under sex variable, if I see one, I know that it means male. And if I see two, I know that it means female. For variables like suspected disease, which has multiple entries. So anything 101 there means CBPP, 102 means PPR, 103 FMD, 104 LSD, and so on and so forth. And so this provides clear definitions for straightforward analysis, and it enables data sharing and reuse. And this is very important in large data sets, such as data for multi-country study or for One Health collaborations. And in terms of ethics and privacy and data ownership, number one, there's a need for ethical consideration. So informed consent first, especially if you are working with patient data, well, especially in human cases and, well, even in veterinary. So informed consent from the farmer. And confidentiality statement when I was working on epidemiology, risk factors for confirmation of slaughterhouse confirmed cases of bovine tuberculosis in slaughtered cows in Great Britain. We signed a confidentiality form that said, number one, after finishing this analysis, if you want to publish it, we must agree with the content. And then two, you have to destroy this data set, including all the backups after the analysis, after you have achieved what you want. And the storage has to be secured and responsible data sharing platform. Well, it doesn't make sense sharing your data set through WhatsApp. Email, fine. And I think there are other platforms for data sharing. I have never used them before, but somebody else mentioned them to me, I think, last year. So trust is the currency of data systems, in summary. So from data collection to decision making, we are not just collecting data for nothing. We are collecting data to provide solution of, informed policy recommendations. So for outbreak alerts, we know what to do with them. Vaccination scheduling, and for risk mapping here, I included this data for a study that I did some years ago in Great Britain, looking at risk factors for BTB confirmation in slaughtered cows, and where we confirmed that the southwestern part of Great Britain, farms there have higher level of BTB. And then we recommended that intensification for bovine tuberculosis surveillance, or bovine tuberculosis surveillance should be intensified in the southwest. And they have a kind of testing intervals, which ranges between 1 to 4 years, parish testing intervals. So the PTIs in the southwestern part of Great Britain is on 1 yearly basis. So every year, these animals are being tested for BTB. And then for farms up there in Scotland, some of them are being tested on 3 years basis or on 4 yearly basis. And some of them, we don't even test them because they are negative for bovine tuberculosis. But then we are asking for policy review because if you say that you are not going to visit those farms until next 3 years, the bovine tuberculosis may build up even within 2 years or 1.5 years. And so that is policy formulation here. And that applies to this data set by Jennifer Claridge in my research group at the University of Liverpool. So here she confirmed that more cases of fasciolasis in dairy cows or on dairy farms in this part of Great Britain, but less or zero cases of bovine tuberculosis. And then here in the southwest, more cases of bovine tuberculosis, but less or zero cases of fasciolasis in dairy cows. So here we are turning records data into tools. And so my key take-home messages here in summary, data collection is the foundation of data-driven livestock systems. And I think we should keep this at the back of our mind. And there are simple tools that can generate powerful insights, and quality matters a lot than quantity. Having a very big data set that is of poor quality doesn't make sense, or it may lead to a wrong conclusion. And then people, tools, and systems must work together to achieve a common goal. And then I put something here as my closing thought, which says the best decisions in animal health are not driven by assumptions, but by well-collected data. And that data has to be captured consistently, and it should be interpreted wisely, and it should be used responsibly. And here are some of the references that I consulted in developing this presentation. And thank you so much for listening. Thank you.
Amazing. Amazing. Amazing, really. And we want to thank you for this very thoughtful presentation. You know, I'm tempted to talk in between, but that will not be good for our timing. So I'm having the biggest restraint possible to allow all the presentation, then we will now go into what we need to do. It's not going to be all lecture, lecture, lecture. At the end of the day, we have to sit down together and make a few decisions to move the livestock sector forward in Africa. And that's really the goal, because the title of this show is Advancing Animal Health in Africa. And Dr. Shittu just mentioned profoundly that it's not going to be done by assumption. It cannot be achieved by assumption. You know, there's been it and because it's not going to be done that way. There has to be a strategy of ensuring that this works. So on our list, finally, before we go into the interactive session, if you have questions, you can put it on the chat box or raise up your hand. It's somebody that is highly respected, really. Had worked in South Africa. He was moved to Tanzania also to head ECTA, then to Nairobi, Kenya, then to Sudan. Then, of course, he's currently with us, but travels everywhere consulting about the same issue. He's a One Health intelligent expert and also have a really very strong background in epidemiology. I think I want to also proudly say that if Farmalat, if you like anything Farmalat is doing, we have a set of 8 advisory board members, including our lawyer, 7 advisory board member, lawyer making 8, and he's the chairman of our advisory board. So his wisdom has been utilized to move quite a bit of what we do in Farmalat forward. So, ladies and gentlemen, I'd like to give it up. So let me spotlight him to Professor Fasina, Folorunso Fasina, to take the next 20 minutes and telling us about how to move from farm to the future, One Health surveillance for outbreak prevention and vaccine strategy. Thank you. Prof, it's over to you.
Thank you very much for giving me this platform, and good morning or good afternoon, all of you. Really, with the presentation of Zainab and that of Shittu, I don't know if I still have to talk. And well, I'm called a professor, so you expect a professor to talk a lot and possibly give an exam at the end of the presentation, but I will not do that. Today, I'll do the role of a marketer to market what both Zainab and Shittu had presented to you. So basically, we are considering the issue of data, and data is really very powerful. I always consider Africa to be data rich, although our data are very scattered. They are all over the place. We didn't put them together in one place. And that's why we often think that we don't have data. So we go through just some few slides, and I'll be tying this issue of data to One Health surveillance in terms of outbreak prevention, vaccine strategy, and control. And when you think of One Health, we have to think of neglected zoonoses, which are prevalent in Africa. We have to think of food safety. We have to think of emerging infectious diseases, which we battle with all the time. Think of antimicrobial resistance. And in all of this, we are not just supposed to be academic in our thinking. We are supposed to be building business cases. For example, if I found this percentage of reduction in my milk, what does it translate to in terms of business case? Because farmers are not interested in your story. Farmers are interested in what ends up in his table in terms of output. The community are not interested in your story or in your theoretical narrative. They are interested in what will keep us healthy and what will keep us to spend less money on drug. And so you need to be able to think constantly of how to convert your data to useful information to trigger public health. So let's look at the big picture. This statement had been overused so many times. 75% of emerging diseases are zoonosis and all those things. And so we are all familiar with this. If we look at this map right on the right-hand corner, these are some of the diseases that have been linked directly so many times in different parts of the world to different animals. So we've had avian influenza, swine influenza, Spanish flu, Zika virus, Ebola virus, avian influenza, SARS-CoV, COVID-19, so many other ones. And so the point is that all this information that we've gathered over time from this disease is why are we still having disease at this time? So the key point is that our livestock data can become our first line of global defense, depending on how we use them. For instance, the first set of outbreak of avian influenza we had in Nigeria was between 2004 to 2006. Why are we still having avian influenza occurring regularly, even in Nigeria? What have we done with all the data we gathered from 2004 up to 2009, 2012, and thereabout? So we need to keep thinking about this because the next pandemic may start again from the farm. And that is why our data could stop such things. So when we look at bridging the talk from practice to policy, it's not just about talking to veterinarians, talking to animal health experts, talking to policymakers, but we have to think of how our talk will go right from the farm, right from our veterinary practice, right from the clinic, right from the abattoir, and lead us to take One Health action through the data that we've collected. And so basically, this is what I would be emphasizing from our data practice, the data from practices and from production systems, the data, how we process them through some data tools that have been emphasized by the two previous speakers, and how this fuel One Health surveillance and our response. So basically, what is One Health surveillance? This is about integrated monitoring of human, animal, and environmental health data. For example, when we talk of anthrax, if I pick anthrax as a case study now, in East Africa, majorly Kenya, Tanzania, Uganda, the Maasai call the anthrax. They call it early rain disease. That's the literal conversion of the Maasai word for anthrax. When you look at it, why do they call it early rain disease? It's because at the beginning of every new rain, they have an increasing surge of anthrax. But this information that the Maasai had just narrated, how does it make meaning to the public health and veterinary community? If they are thinking critically, why do they call it early rain disease? This is based on observation from the farmers and from the livestock owner. Then, how should we interpret those information? This information means that at the end of, during the drought in the previous year, there is no much grasses in the community. So the Maasai moved their head into the bush, into the wildlife area to eat grasses. Remember that in the wildlife area, You may also have some wild ruminants, like the gazelle, the impalas, and all those things that died from anthrax. And this because the wildlife authority, the wildlife rangers and the authority, they are not interested in animal disease report. They are more interested in preventing poaching and ensuring that ecotourism is boosted, not in wildlife health reporting. So when they see such animal that died in the bush, they just record, oh, we saw one animal in this place, one impala or one gazelle died there. And that's all. They never bother to report to veterinary authority. Then this animal get rotting on the surface. And at the end of the day, the carcass is there. And you know about anthrax. The anthrax spore does not die easily. So it remains with the animal. When the livestock come in to eat grasses there, they pick some of this spore. And by the time they return to the community during the next early rain, they begin to die due to anthrax. And these are doing a cycle every year. So what can we as veterinary authority think of those data and how do we convert it to information? Because even when this animal begin to die in the community, the livestock is flayed, the dead one, and shared among the community. That is the normal practice among the pastoralists. And so you see one or two cases of anthracoides in human, and typically it's first picked in the public health clinic. They say they report back to the community and they trace it back and manage the community. Then they link it back to the wildlife. So you can see how the data move from the domestic livestock into the human health clinic. So it's not just more data that we need, it's smarter linkages that we need. If you look at this picture that I showed here, it's actually talking about that. In the wildlife there, you see a lot of interactions that are happening. The exposures through wildlife, we've also picked, for example, antimicrobial resistant gene in wildlife. These animals in wildlife, they are not given any antibiotics, yet we pick gene from them. Where do they get this gene? It's through their interaction with livestock. When you look at the environmental exposure, like in Zamfara and Sokoto State, not too long ago, we've had cases of lead poisoning, we've had cases of environmental contamination. How does it affect human? In our food web, food system, how do we pick infection or how do we pick resistant gene from animal? All these are important. So when you look at the farm as a whole system, our farm are real biosurveillance nodes. So if we will take data critical in every farm, you will find out that we will stop disease early. For example, milk yield. So milk yield is reducing. Something must be happening. It's either a condition that is affecting the animal or disease situation or a syndrome or something is going on. You need to look at it critically. Feed intake, if it's reducing in poultry farmers know the importance of feed intake reduction. When you talk of movement log, how do our animal move? Where do they move to? If you're taking note of how they move every year, by the time they move through some corridor, if they always have disease after such movement, then you know that something is happening in such corridor. What of our morbidity rate? Do we just take them casually or we take particular note of those information? Mortality rate, the birthing, the number of kids that our goat give birth to, our sheep, our animal, our clinical record, our abattoir record. Dr. Dambazau spoke critically about those information, and Aminu Shittu also emphasized it. These are the things we need to be considering as we move along. So the thing is not just to collect data. You know, when you have so much volume of data and you don't convert them into useful information, you are just like a waster, or you are like somebody who has so much money in the bank and you are dying of poverty. So you are not converting your resources to something that is useful and that can help you. So we need to keep thinking constantly. This set of data and this set of parameters I've got and I've collected, how do I use them for information? For example, just about 4 or 5 years ago, I had a PhD student that approached me. He wanted to work on salmonella in Nigeria. He was leading a project in the north central part of the country. And so he had access to a lot of data. He was thinking, what should I do for my PhD? I said, Ben, you are sitting on a lot of data. Why don't you do a data-driven PhD? And we designed what he needs to do within his project. You'll be surprised that within a space of 2.5 years, he was able to finish his PhD because he has so much data that he was sitting on, and he was able to produce 6 publications in a space of 2.5 years, quality publication from the data he mined, and he was able to produce some key outcome that surprised even the ministry where some of those data were retrieved from. So we have so much data. If we look at the records that maybe exist in our ministry in the last 10, 20, 30 years, if you just do trend analysis, you just do some simulations and all those things, you'll be surprised at how much information you can generate from those ones to then trigger decision making. You can look at the cost benefit analysis based on those data. You can look at so many things. And this is how we should be thinking in our mind. So when we look from lab, the whole system is one. For example, you went to a farm, you collect sample, you put it. At the end of the to be aware, and you want to create informed decision, and this should be the sequence. We shouldn't just think of, oh, I've collected data, I've published, and that is where it ends. You need to create that with the quality of information you have. You know, the people in the front line, your community animal health workers, your farmer, the community itself, they are really want it, but they understand and know what exactly is happening with the animal health world. For example, I once had a student in South Africa. We went to the field. Why are these pig farmers, these smallholder pig farmers, why are they just stupid? Why wouldn't they just adopt feeding commercial feed to their pigs? So when we left the farm, I called, I said, okay, now Priscilla, this will be your master's topic because you've identified this problem. You have to tell me why they don't understand or why they don't adopt this. And she started this work. By the time she finished, she found out that at the scale of production, they cannot make profits if they depend entirely on commercial feed. And that is why they are now using that's why they're using swill feed mixed with other things to feed their animal. And she found out that they can only be profitable by the time they scale up to at least 100 sow units in at the front line level is very important. For the legal borders, government no. Illegal borders, government will not have a hand on it. But the community who lives in the border, they know all those illegal borders and they can tell you with precision. When you look at issue of cross-border marketing, the farmer know exactly the pattern of those cross-border marketing, and they will tell you with precision what you need to do to mitigate such a thing. And so we need to be thinking of what incentive do we provide to our farmer to help them or to our community to help them in terms of willingness to report. For example, can we create better market access for them with our policy? Can we create some sort of insurance premium for them so that they can have better earning for their production? Can we help them by triggering early warning, things they can do on their phone that they can check information and all those things that will help them? So this type of simple technology will help us to get better adoption even from our farmer. So in terms of data-driven vaccine planning, for example, you've collected all this information and have identified all the high-risk disease corridor. And now this can help you in your planning. For example, the picture you saw down there, they are from South Sudan. And these are vaccine cold chain facilities set up in South Sudan. We have 142 of these spread around the country. And how did we arrive at this decision? First, we look at the whole country. You know, South Sudan is a very hot country. So initially, they do have problem with vaccine, both human vaccine, animal vaccine. By the time they take it to the extreme part of the country, the vaccine had become water. It's not useful again. And so through cooperation from UNICEF, FAO, and some other And for logistic purpose, everybody keep their resources in this too. And it's a deployment site now, and it make the vaccine closer to the people. So in terms of movement corridor, in terms of vaccination close to source of infection and all those things, it becomes very fast. And also in terms of surveillance data collection, it makes it very easy for us in this case. So early warning outbreak detection is also important. What are the areas we should be looking at? Livestock mortality, our clinic visits, social media keywords like zero reporting form, like rumor registers, abattoir data, environmental data. Also in terms of our surveillance system, currently, most of the countries, what we do is that we do reactive warning. For example, when you say, oh, we react early warning, how did we react in early warning? There is a disease outbreak. It is when we notice that outbreak that we begin to react. But now what we are proposing is that can we move to anticipatory warning? For example, if you look at that graphics at the bottom, you see, when you begin to sense environmental monitor, for instance, if we pick the case of anthrax now, before anthrax occur, rain may have fallen. When this rain fall, it dug up all the carcasses that are not very deeply. And then you begin to notice that there may be an indication that there will soon be an anthrax case in the community. So if we follow this lower trend compared to the upper graph, the lower one is telling you about anticipatory warning. Immediately you begin to see those monitor. For example, if you see that green cycle, that is where the monitor anticipatory vaccination and a lot of the outbreak that will occur. But currently, what we do is that we wait until the first or few set of outbreak occur, and then they begin to skyrocket before the veterinary service come in and take action. And so this is why it increases our level of waste or our level of loss. So we need to begin to think of anticipatory early warning to detect disease early. So in terms of connecting our One Health dashboard, we need to create a sort of dashboard. This is the ideal that should have multiple panels where you can integrate public health, animal health, environmental health, as well as even under parameters, maybe like the geologic parameter, geographical parameters. And these are the things that the policymaker need to use. You should also make it simple enough to be able to communicate with the policymaker. In terms of technologies and tools for integration, I will not emphasize this again. Dr. Shittu had already talked about them. So the benefit across the value chain is that first, the farmer has reduced losses and better prices for their product. For the vets, you are able to create timely care, less antimicrobial, less drug, and professional growth. In terms of the government, it lowers the cost of implementation and it improves food security. For all of us, we are preventing pandemics and it's benefiting all of us. And the 3 steps to start, because we should start like tomorrow, which is like today now, because I prepared this slide yesterday. One, we need to begin to digitize our One Health record. Every opportunity we have to digitize our record. Put it down, just write it down. Even if you don't have a formal, nice dashboard to never know when that will become important. We need to begin to map one data flow, okay, from farm to vet clinic, to the district, to the region, to the national. We all need to talk to one partner outside your sector. So you see, you collected all sorts of information on anthrax in livestock. Why wouldn't you share it with the public health officer in your region so that you begin to take action together? So the future is integrated data. Data collected in isolation will save only one animal. But when we share data across sector, we are saving the herd, we are saving the community, and we are saving the nation. So basically, I just want to recap by talking from data to decision. One, imagine you collect raw data. You quickly enter it into the app that the government had created for you. It went into the analytic tool online, and the data is processed and it predicted a disease, let's say PPR in this case. And then from the visual dashboard, every community in the neighborhood or in the zone, maybe senatorial zone, are able to see this. And they begin to send alert to farmers in the high-risk area. And then vaccination campaign was launched earlier. And then outbreak was quickly contained. And in total, we saved or we prevented about $200,000 avoidable loss. So this 200,000 avoidable loss that we prevented can be used somewhere else. So in summary, I would like to recap, since I'm the last speaker before we begin to discuss, just on what everybody has said. Data collection and digitization is very, very important. We can use the tech, we can use our basic tool like notebook, standardized template, and stakeholder need to be involved. Data integration and centralization is key. For example, we can merge data together. We can use all these API online. We can use interoperable tools so that we can migrate one data to the other. And we also see that platform is linked to data. Data analysis and modeling is critical. We don't just collect data, we need to model and integrate them and analyze them. Visualization and reporting is key. The decision support system is important, following data use and stakeholder engagement and feedback. They are very critical. I would like to stop at this point and say thank you for giving me this platform.
Fantastic. Fantastic. So when he started, of course, we all know he's a prof, and we were expecting something professorial. So I got a bit very jittery when he said he will switch into his marketing mode. But that was brilliant, Prof. That was extremely very brilliant, from farm to the future. And what a way to cap up. I'm going to take the next 3 minutes to share what 5 minutes really, what Farmalat is doing, so that it can also be part of the total conversations that we are having. We're going to have like 45 minutes. By 1, we should be done. 45 minutes of interaction, questions. So you could raise up your hands, you could type on the chat box, and then we could get this done. But so that to make the presentation a bit complete, Farmalat, Prof, if you don't mind, bring down your screen so that I can quickly just share mine. And then we can bring all stakeholders on board. The last 2 years, Farmalat has been working on an AI-powered tool. Right. And I give a quick example. So we all know the problem. Data are isolated. Prof just mentioned that if data are isolated, you can save an individual livestock. But to save our livestock collectively, then data needs to share a bit more in terms of collaboration. And so, we picked example from the Nigerian system, where you have the refinery not working that much, and then a private person in the name of Dangote Refinery came in and built something that could be used as a model and exported across Africa. So we picked that same energy, and we thought that we could start doing something in Farmalat to help in this regard. Okay, Prof, you're still sharing your screen. If you stop sharing, I think, okay, well, fantastic. So we thought we could start doing something in Farmalat to see how we could solve this issue. And I'm going to be making a quick presentation on it. Quick presentation, just a moment. I'm trying to look for bring up the presentation. All right, so for the last 2 years, we've been working on something that will be driven. So I see hands raised up. You will be acknowledged very soon, just 5 minutes. We've been working on an AI-powered platform that makes animal health simple. And what we want to do in this first phase is to have a platform that aggregates data and does 2 things specifically. First, to give you vaccines availability. PPR, people get to call our warehouse. Do you have PPR? Do you have CBPP? Do you have these vaccines? So we want a situation where we could alert people, the entire livestock community that we have, where vaccines are. More importantly, not to announce outbreak, but first of all, to gather suspicions and then channel it to the ministry, and if confirmed, to also be part of the platform that announces outbreak. We have also built simple tools into this to ensure that we can at least capture farmers' data and capture animal health professionals. So there are three users for the platform currently. If you're a farmer, you'll be able to, of course, get outbreaks data from us, vaccination reminders, and also digitize your health records. I know we've done this over and over again and we've overflogged it, but I'm going to be sharing the link, the test link for you after this meeting just to see how well it works. With the second set of people are the professionals. We're going to be verifying professionals and giving them access to our database. So if you say you are in Adamawa and we have enrolled farmers in Adamawa and they have any issue, we're going to be linking those farmers to you directly. We're also going to be giving you simple tools to submit your health records and also expand your network. Then we have the third category, you're a volunteer. Because we won this at the end of 2026 to have 2 million individuals. We're targeting 2 million individuals. So we will be willing to recruit volunteers who will enroll farmers who will be part of our community outreach and who we can also track their impact to say that they are doing something to make a difference in the livestock sector. The next thing we'll also be doing, integrating to this, Prof talked about it as what they have in Tanzania. So we are now creating a national vaccine grid using VaxiCare. VaxiCare is just an innovation that Pharmalat has currently just developed. And what's VaxiCare? It's a small box. It's not as big as what Prof just brought up. It's a small box and is available now. We're going to be deploying the first 100 across northern Nigeria, first quarter of next year. It is powered by battery, not solar. So that means if you have power, you can easily plug it and it can take you an entire 24 to 48 hours without losing the temperature. It has SIM cards in it for us to track the locations of these boxes. It can also be carried to the bush once it is fully charged and preserves your vaccine. It's 15 liters. And then, of course, it gives us, we're integrated in the FarmVax platform, is the temperature of all these, the humidity, every parameters that matters for tracking whether a vaccine is okay or not. And that this VaxiCare will be building it into into our FarmVax app. So the main site for FarmVax is farmvax.com, but it's not available. But we created a text link today. And so I'm going to be sharing the test link in the chat box now for you to go in there and feel what it is like. Register as a professional if you're a professional, register as a farmer if you're a farmer, and then help us build a community where data won't be so much of an issue anymore. And then we can work towards something that can be meaningful. Of course, if this platform works, we are also going to be approaching the ministry to see how they can use our platform free of charge to be able to reach the millions of farmers we are hoping we're going to be able to enroll, and of course, to be able to use our national vaccine grid to give vaccines to places that are rarely being touched by our current distribution model. So that's what Pharmalat has been working on for the last 2 years. And by first quarter of next year, I think we'll be deploying the first version. All right, so much about that. I will now, at this junction, bring up all our hub experts. So if you don't mind to turn on your video. So I'm going to be bringing, Professor Fasina is already on. I'm going to be adding Dr. Aminu Shittu back on the stage. Back end, Dr. Zainab, are you on? I know you said you want to drive to work, but this is the time to now interact and get people to talk about what it is that we have spent the last 1 hour discussing. All right, she says it's on back end. Please help us make our co-host and let us hear her out. The first person I'm going to be recognizing is Professor Olufemi Adebiyi. Professor Olufemi Adebiyi sounds like a familiar name, but sounds like a familiar name. I hope well, I have a cosmate, but since he's a prof, I don't know whether that will be it. A cosmate in ABU who was Femi Adebi. So, but again, I will be pleasantly surprised if he's the one. Then I will have to think about my life again. Why I have not finished my master's.
Yeah, good afternoon, everyone.
Yes, good afternoon.
Well, yeah, sorry, this is not from This is not Adebi Olufemi from Zaria. This is from
Okay.
UI.
Okay, all right, good. All right, now I'm at peace.
So don't worry, you are on track.
All right,
Don't worry
thank you
about
so much.
that. Well, thank you so much for the presentation. I really want to appreciate the three presenters. They have actually done justice to data collection and data issues generally. But my concern has been getting a reliable data. Because why I lecture in the University of Ibadan, and I've been as an animal scientist anyway. I'm basically into monogastric production and management, and I focus more on swine. And of course, when we are talking about swine, the only thing that relatives come to mind is the African swine fever. Yeah, so I've been gathering some data on this issue. But one thing I realize is that many farmers, because we all know that hardly do we have big farms, and these big farms have record, but many of our farmers are small, scattered everywhere. So many of them don't have record. In fact, there was a particular time I had to visit a particular farmer on two different occasions, and I got two different response from the same farmer, the same question, twisted in a different way, two different questions, two different answers. So how can we get a reliable data? Because if you don't have a reliable data, all our assumption policies will be wrong. That's one. Then secondly, the second one is tracing the value chain of all our business. Because if you are just focusing on stopping it at the farm sector, what about when these animals were now turned into products? It's a way of spreading many of these diseases. Do we have enough data on tracing, on traceability of the value chain of these products? I think I will need clearance on those two. Thank you so much.
All right, Prof, that was a jam question, but again, we have a matching prof to to do justice to the question. Prof, you want to take this? And Dr.
Yes,
Aminu,
yes.
you can turn on your video so that we can at least add you up to the
Yeah, thank you very much, Professor Adebi. It's really a very good question, and really, it's what we need. There is the thinking we need if we really want to get ahead of ourselves. Currently, by the way, I also have a lot of interest in pig because I did my PhD on ASF. So it's an area I'm very much interested in, and I've worked with pig maybe since 2000, since 1992 when I was a student at the university. So on this issue of two different answers from farmers, definitely when you are dealing with the farmer, you know, most of the answers you get from them are perspective. They may not be real empirical data, but this perspective they are giving you can lead you to something. For example, I will give you a quick answer. If you've dealt with farmers now, you collected information from this farmer, this farmer, this farmer, maybe like say about 10 farmers. If I'm asking about your production record and you tell me, oh, my pig give birth to 20 all the time, because you are a vet or you are an animal scientist who knows and you are asking him, he will give you what we call answers that are called courtesy biased in epidemiology. Those answers we have courtesy bias. He knows that you should know as a professional. So he want to give you near the real answer that you should be expecting. But by the time you gave me those answers, I will walk through your pen. I will just take random picture of like 2, 3, 4, 5 sows that are giving birth in your head. And if at the end of the day, I count the number of piglets I can see with each of those sows, if the average is 12, and you tell me your pig always give birth to 20, I know that your margin of error based on the response you give me is about 30 to 40% immediately. So I will use that to benchmark what you do. So those are the type of checklist that you need to put against the data set you collect from this type of people. And then also the more data you collect, for example, instead of collecting from 2, 3 farmers, can we collect from 200 farmers? It increase the power of your analysis and reduce the margin of error. So with this, you then use the average of every information you've collected to do your analysis. Times you can also do expert opinion survey. For example, the expert in that field who are relating with those farmers, you can also collect their expert opinion to triangulate against the key data you collected from farmer. So with this type of thing, you can reduce the margin of error. We've done this a lot of time. Indeed, the PhD student I talked about, he did that because he was working with poultry in north central Nigeria and was collecting data on salmonella. And by the time he did this, we collected quite some robust set of information that even the ministry were requesting for those data that he produced at the end of the day to help their work. That is one. On the second question, what about the traceability and the value chain? Yes, rightly. So when you talk of data collection, we are not just talking about the farm level data collection. It's the whole of society approach that you need to think of. For example, if you are dealing with economic data will not only come from the farm. For example, let me give you this instance, which we observed in East Africa. Just when you talk of African swine fever, do you know that the middlemen intentionally come to seed farm with ASF so that people will sell under panic buying protocol and they can buy cheap and then slaughter and sell to the field. And these are the middlemen themselves that told us this. They said, no, when they see an infected farm, they go there, pick infection, then bring it to area where there are no outbreak. By the time one farm begin to have outbreak, everybody in the community begin to sell cheap. Then they, the middlemen, decide the price at which they buy now. So you can see how behavioral risk communication affects the farmer now. Although the farmer are not the primary sinners here, but they become the victim in this case. So when you are doing your analysis, sir, it is good for you to think of the whole value chain analysis and begin to collect those information. You never know when the information you collect from an ordinary farmer or from a marketer or from a transporter will become very useful. For instance, also in Southern Island in Tanzania. There's one of the major pig up in Africa. We were discussing with the farmers there, and before we got there, the regional veterinary officer told us, he said, I know practically everything about the Southern Island because I've worked there for more than 20 years. We said, really, you know? He said, yes. When we now went to meet the farmer, we had a very good meeting with them. What we did was to separate all the professionals, the vets, the animal health officer, and all those things, separate them into a separate room. They pull together all these people they think don't know anything and cluster them into two. And then they begin to discuss and open up and elaborate it. By the time they finish, and we come back to the plenary session, and the people from this group they thought does not know begin to give us what they discuss in their group. The man who claimed he knows everything about the community, he opened his mouth and will say, hey, so this had been happening under me. For example, one farmer told us how he moved infected carcasses. He know that his carcasses are infected, and he moved them over 1,200 kilometers from Southern Ireland all the way down to Dar es Salaam, and caused infection in a lot of places in Dar es Salaam. He said it, and he told us, and there were so many police and checkpoints on the way, and not a single one of them detected him until he did that. So you cannot bypass any of the stakeholder if you really want to collect good set of information. Thank you.
Prof, you know what you've just said is so so enlightening and frightening at the same time. Because back end, please, if you can make Dr. Zainab co-host so that I can bring her up and she can turn on her camera. Dr. Shittu too, if you could also turn on your camera so that I can bring you upstate. But you know, the challenge is, you know, sometimes I don't think I think whether knowledge is also an hindrance to progress, because so look at it. You said the people who knew, they took them to one side, and the people who didn't know. Meanwhile, the people who are really making things happen and destroying things are the ones who people think they don't know. And that's why data has to be from bottom up. If you want to get it from up to the bottom, you will probably miss the insights you need to really gain. And for us as a country, I think we should not take data as an option any longer, but to have a strategic way of doing this honestly from what it is that we're engaging. So thank you so much, Prof, for that useful insight. I'm going to ask, so two people are raising up their hands. You just ask very fast. and then we will go to the chat box and start reading out questions. So I will take 2 questions at the same time, Dr. Rodia and then Dr. Mohammed. Well, I don't know whether you're a doctor because it's a mix platform, so of both veterinary and paraprofessionals, but whichever way, I think it's your question that we will need to. So Dr. Rodia, quickly, what's your question?
Okay, good afternoon, sir. Thank you very much, Anma, for the session. My question is directed to all the speakers. How do we aid data collection? I mean, the vast majority of these farmers that would be needing data from are not particularly educated. So how do we aid data collection considering the urgent need? All the speakers have spoken about the importance of having accurate data, having a valid database. But how can we aid it in a country, in an economy with high level of uneducated people among farmers? So what strategies are in place? What can we also utilize if we have intent on collecting data?
All right, thank you, Dr. Rodia. Let me match you with a doctor. Dr. Zainab, you want to answer this?
All right. Yeah, sure. But I was finding it hard to get her entire question. But did she ask how do we aid data collection? Was that your question?
Yes, that was it.
Okay. Dr. Rodia, we'll have this a little bit conversational. Where do you work?
Well, she works in Farmland.
Okay, it starts from her. Yes, so Dr. Rodia from Farm Alerts. When you were asking that question, I'll say, let's forget about the books, let's forget about the literature, let's come local. How do we aid data collection? I'll ask you back, how do I aid data collection? What things can I do as a person where I work with the resources I have to aid data collection? As I mentioned earlier, data is not, if we say technology, is not all about technology. It's about structure, it's about speed, and it's about using it for decision making. So how do I aid data collection? First, you have to be strategic. You have to have structure. What are the variables that are in your data? It's not just about collecting the data. To aid data collection, you have to have a structure for that data set. What are you aiming? What is your objective? If you work in a clinic and from veterinary school, you are being taught that as your client walks in with the animal, that is when you begin to assess the gait of the animal, how the animal is walking. Are you taking that into consideration? When you start to do the physical examination, what are you taking? That's all aiding your data collection so that by the time you have that as a person, I believe that aid starts from you. It's not from the system. Stop looking at it from the system. Look at it from your own self. How do you aid as a person in your clinic or in your farm where you work? It starts from structure. To have a structure, I feel structure is what aids collection. All right, thank you. I hope that answers it.
Yes, and it answers it brilliantly because, sometimes when we ask some of these questions, the question doesn't put the responsibility back to us.
It doesn't, yes.
Yes, the question puts the responsibility back to the government, back to the CVON, back to professors.
It puts it back to everyone. And just to add my voice to this, when we talk about One Health, nobody should quote me. We're really doing well. But are we really doing optimally? Why do we always feel that at meetings we'll begin to say, oh, we feel sidelined? It's because we don't have data. So how do we aid that? Dr. Rodia, back to you. It's not back to the system. So if individual veterinarians do not aid data collection, probably the high level or the top level can give us a structure for everyone to adapt. But if we have it, are we using it? I mentioned that 2 years back, was it 2 years back, someone was, I think it was Dr. Shedrack, he has this application for
Yes,
collection.
yes,
Are we
yes,
even using it?
yes, yes.
I think I've had it on my phone, but because I'm not in the clinic, I'm not using it. But those of you in the clinic, are you using it?
Yeah.
Many people have come up with a lot of strategies,
Yeah.
but are we adapting it
Yeah.
as veterinarians? I think we should ask ourselves those very, very painful questions.
And you know,
before we throw it back.
you know, as I said earlier, we've been on this for 2 years because we see also the problem, right? And your answer, it's a bit profound because once responsibility starts shifting to the individual.
Exactly.
And I'll give you a quick story before I pick up Dr. Mohammed. Somebody asked a senior person that how do we gain good leadership in the country? And then the person said, no, you should pray for good followership. And you know, because if everybody is a saint, if everybody is a thief, and then the person leading is a saint, the person who is leading had two options, either to become a thief or to get thieved by the people who are clothing him. So I think everything just comes back to us, and that's very thoughtful. Mohammed, you're raising up your hand. Can you unmute yourself? And then I would start taking questions from the chat.
Thank you, Femi.
Dr.
Sanusi Pagi.
Is our chief.
Yes, is our chief, and we are classmates.
Thank you, Farmalat, for providing this platform. Thank you, the able speakers. Zainab was my cohort for the fellowship program. You are doing an amazing job. Well done. Just a contribution. I think we need to inculcate a culture, and to build a culture, it has to be over time. I don't think we have that culture as veterinarians. Maybe in our training, we need to do more in our curriculum to inculcate that data collection and record keeping. Because in 2014, I was posted as area veterinary officer of Rano. When I got to Rano, I saw records from 70s, 80s, very good records. Not written by veterinarians, mostly by superintendents. The last record I saw in that clinic was 1995. And from 95, what transpired, vets took over, and then the records disappeared.
Whoa.
So I think we need to do more. Also in area of mentorship, we need to mentor those behind us to see the importance of this. Thank you for this brilliant discussion. Thank you.
You know, thank you, Dr. Sanusi. I'm hosting, so I'm not supposed to be asking questions, but just a quick question before before I go into the chat. So, you know, he said something that they were done by superintendents, and in 95, that was the last record vet took over. Is it our training? Or we know too much that we don't need to write. So
let me help you with that.
Okay, go ahead.
We get a lot of training, and by the time we come out, we go doctor. Please, doctor without data. I don't want to say it's not doctor, but it's doctor. But it's not. I think we need to change that. Dr. Sanusi, I think we need to change that. And there is no harm in training professionals, paravets that work with you. They do well with collection.
Wow.
Just own it yourself. It's a team. Wow. You cannot do it alone. You want to go far, you go together, right? Yes. So it's a team. So there is really nothing wrong in training because you are saddled with other responsibilities, and it falls back to us. We created the problem. We as veterinarians, we created the problem. But as I said earlier, when you look at barriers and you look at problems, discussions are coming up, and we are owning that we created the problems. We shouldn't just push it back to the government. We shouldn't push it back to senior colleagues. At some point, at wherever you are a stakeholder. So that sums it up.
You know, when we're growing up, if you see a doctor write paracetamol, you need to be a genius to be able to say it's paracetamol. Paracetamol, it's like over the years we've been trained that the more mysterious we are, the more that we become. And so your answer around training paraprofessionals might just be, because I don't know, or maybe we should stop calling ourselves doctors. I really don't know. Somebody is saying, Moazu is saying, I'm from Zaire. Please, how can we contact the public health officers to share any data collected or analyzed? So you see, there's this outcry that people have. If the structure, as Dr. Zainab has rightly said, is provided, maybe from the top bottom, I really don't know what answers to give now. It can be multi-sectorial. Dr. Aminu, you want to answer? He's asking if he wants to collect, he has data, and he said he's a public health officer, and he's collecting data. How will he share his data, and he's from Zaire?
Well, I think having worked in the UK system and in the Dutch system before, in the Netherlands, where it's a system, I'm finding it difficult to work with data or to generate data. Well, in those systems, I work with bovine tuberculosis data, which was recorded as far back as 1950 or even 1930. That was when the typewriter was being used, or even hand recording system. We requested for that, and the whole thing was gathered for us within 1 week. We requested for it on Monday, and we received it the next week. So it is easier to work with, to get data in those societies, in those environments, and even the issue of traceability that was asked by that professor of animal science. Every egg in the UK or in Europe is labeled, and that label, that code, is a unique identifier for the farm of origin of that egg. So if there is an outbreak of gastroenteritis or anything foodborne disease following consumption of poultry or egg at a party or in a restaurant, the source of that egg can be traced using those codes that were stamped or printed on the shell. And also with the slaughtered animals, they have unique identifiers either on their, on the air tag or on the digital system. So whenever a case of tuberculosis is detected on a cow, it can easily be traced back to the farm origin, and then a decision is making whether to test and slaughter and etc. But here, if you are a researcher, either doing a research or a PhD, you have to generate data by yourself. So you have to start from the scratch. But there are certain systems that I have mentioned where data exists, but we don't know what to do with it. I went to greet one of my friends who is working in a federal medical center in the ophthalmology department. They have so much data on which was written on the file as far back as 30 years. If that data can be imputed into the spreadsheet Excel, we can do an excellent analysis for that. Even if not for the sake of publishing, you can tell the government that, look, this is what is happening. Like I'm holding another data from the veterinary clinic, state veterinary clinic, which is a large data, and data from I think last 5 years of cases and different treatments. So that kind of data, when analyzed, I can advise them that, look, you have more cases of helminthiasis, so your pharmacy should be stocked with antihelminthics, maybe during the month of May to October every year, or you have more cases of Newcastle disease during cold season, and you should be expecting, you should prepare to receive new cases of Newcastle disease between January to March, for example. But then for the last person asked for on how he can share his data. Is he interested in sharing his data for something, for collaboration? Is that what he asked for?
So again, so ideally we have pockets of these, there's a pocket, volumes of these health professionals scattered across. And as we said, these data are isolated.
Yeah.
And this person is on this call and said, I have data and I'm from Zaire. What should I do with it? How can I share it?
Yeah. Well, you have to collect data. If you are collecting data, there has to be a reason for that. And what are you trying to achieve? And well,
No,
that is
so
one of the
if
essence
you
of collaboration.
if you allow me to
Yeah.
come in. So Dr.
Yeah.
Sanusi just said that he had data, he was managing something, and then there were data as far back as 30 years, and it stopped by 1995. You're now saying
Yeah.
you have data for the last 5 years. I presume from Sokoto, Dr. Sanusi
Yeah.
from Kano, this person is from Zaire. So you see,
Yeah.
there are thousands of people having isolated data that
Yeah.
if harnessed, I don't know whether it's going to be our leader. Professor Fasina, you wanted to say something, you're raising up your hands.
Yes, thank you. Just to add briefly to what Dr. Aminu is saying, because for Aminu and myself, we've been collaborating now maybe close to 20 years.
Wow.
And we've worked together on so many data that originated from so many sources, including from outside Africa. So you see, I also try to respond in part to the question that you raised in the chat box. I said at times, you don't need to wait for the formal opportunity to present and share your data or to know how to link your data. For example, if I'm in a local government, I've collected this much data and I don't know the formal way to share it. But maybe when I go to the restaurant, I meet with one of the public health officials, raise an unofficial discussion with him about, oh, we've got this much data. I'm a vet, I'm working in this sector. We are talking about anthrax. These are the things we've got. What can we do together and all those things? At times, a sort of unofficial platform can become a rich source that can generate or lead to something. Also, if you want an official way, for example, if you approach the local government where you are resident, where you need to relate with the public health official, or you talk to your state ministry of health, you may be able to create an opportunity. And with regards to data being available, I can assure you that that is very true. As I said earlier on, Africa is data rich. We don't just know how to use data. I was talking with the former CVO in Kenya at one time, and he was talking about data scarcity in the country. And in one of our trips, we visited one of the district called Nanyuki in Kenya. And in this Nanyuki, we got to the abattoir. The volume of data I saw in that abattoir, I tell you, if I have 10 master students, I will take all of them through those data and we will not finish the data. The thing is that, so it is not only that it is possible in UK or in the US or in some of these countries, it is possible in Africa. As Dr. Zainab has said, we only need our commitment. Don't shift the responsibility to the next person. It's okay, I am in this lab. I will make sure that we have consistent data in this lab. For example, I'm sure Professor Ibuko is also raising his hand. He may want to talk in on this. I know that he had been consistent in some work. For example, if I need to work on Newcastle on some things, I know I will contact him because I know they've had a lot of series of information they've collected over time on some of these viral diseases. So we need to begin to trigger that collaboration internally, even before you make it official. And before you know it, you find out like this platform we are using to share now is an excellent way to begin to create network. Aminu Shittu had just asked a question, if this person is willing to share data now, why don't you reach out to him maybe by WhatsApp or so after this meeting and begin to think of what you can do together. Thank you.
All right. Thank you, Prof. Dr. Aminu, you want to say something? before we allow Professor Ibokwe. Okay, Prof, you're raising up your
No,
hand. Okay, all right, good.
yeah.
Prof, we're asking you to unmute.
Okay,
Good.
I've unmuted now.
All right,
Yeah,
you were raising your hand, sir.
thank you. The discussion is very, very interesting. But what I'm looking at now is the fact that we don't have a data system. We need to have an institutionalized data system. And VCN or any regulatory agency we have in Nigeria has to design a data system where whatever you call it, a dashboard or a system of data keeping can be established. And then when it makes it easy for you at any point where you are, you can request for data and your data will be mined. Our problem in Nigeria now is that everything is on ad hoc basis. We don't have a clear guideline. We don't have any established system for data keeping and for data archiving and for data mining. And there is no monitoring to see whether we are doing that. We don't even teach the students that were graduating, the veterinarians that were graduating, on how to keep data as small veterinarians and how they can connect to a central data bank and feed their data into those places. Like now, if I just want to make a call and say, I want data from 10 private veterinarians, you can't get it by pressing a button. I can't find out what is happening in private veterinary practices in Lagos, or what's happening in Ibadan, or what is happening in Kaduna. So this kind of everybody do your thing, it cannot work, and it can't work in a long time basis. We can't plan very well, and we can't execute very well. I was very excited when I heard Aminu saying that it took them 1 week from one office. They didn't have to go to offices all over to collect data that was kept from 1930. So when are we going to get there? Who is going to start the ball rolling? Who is going to spearhead it and make sure? And this can only come from a policy and established policy, which we can now have a discipline to see that there is some implementation.
All right.
So that's where I'm heading to. On an ad hoc basis, people can share data, probably work on what they have and get it better. We need to have a centralized data hub, like we have suggested before. Thank you.
All right. Thank you, Prof. And this is really what we need to crack. I was part of the Veterinary Council board for 5 years, and we built a system, and some people use it, where if you put the VCN number of a vet, the picture comes out and tells you whether it's registered or not. And then we approached, for privacy, approached a few people that, you can use this to collect data. And that wasn't used. And now I don't know whether how active we are still using that. How do we, Prof, maybe to you, Prof, and then Dr. Zainab, don't disappear. We are rounding up. How do we solve this leadership gap? There's really a leadership gap, because some of these things you can only do. So now we've created FarmVax, and what we want to do is actually is private. We are having vaccines. We want people to have access to those vaccines. So there's profit in mind. So if we give them a way of quickly noticing when there's vaccines, maybe we'll probably help more animal health professionals procure these vaccines, and then by extension, farmers. But we can only do this much. I don't want to say who is to blame, because all of us are to blame. But how do we get the leadership right to start being on the right path to getting this result, Prof. Sir?
Yeah, thank you. Yeah, the Professor Ibokwe addressed some very germane questions, and these are questions that we ought not to be solving now. We thought to have been solved in 1950, 1960. so that by the time we are here, we are already making advance. Because if you look at what our colonial master actually left for us, he left very good structure for us. And we may not even appreciate what we have. I'll give you a quick instance. We have some team that came in from Rwanda and they visited MVRI and they looked at the structure, they look at the whole setup, the national system, how it dovetails into outstation, and how it's supposed to be used for data collection all the way to have a comprehensive lab data. Do you know that while we Nigerians don't even appreciate what we have, these people took this model, they said they are taking it back to Rwanda to set it up. That's how they want to begin to organize their laboratory system. And from the recent information I heard, they already started building their structure that way. Meanwhile, we don't have that. If you look at our command system in terms of data collection, when we used to have the potential military leader from Britain ruling us, you see, there are systematic way of collecting data. I'm sure if we take the 1950, 1960, 1940 data that we collected for animal health and compare it to the data we are having at the moment, we may have more robust data platform than compared to now. So it is a thing we need to do. And how do we do it? For example, like Aminu Shittu has said, we need to have this discussion, for example, with the CVON. And it is not the CVON job alone, as had been emphasized by other comments on this platform. The CVON, we need all our inputs to have good national data at our department level, at our faculty level, at our state level, at our local government level. We all need to be contributing data to the national platform. I know that we have NADIS. I don't know how effective or how rich the data repository in NADIS is. And somebody commented and said, what about data privacy? When you have all this information curated and stored in one single platform, maybe like the NADIS, which we are using for Nigeria, then the CVO can assign different level of data access. For example, the whole national data, who can access it? The regional data, who can access it? The state level data, who can access it? The local government data, who can access it? And if you need to use the data, maybe for your research or to inform policy or for any other thing, you can then seek permission from the CVO and you'll be given access to this data. And this also prevents our country from being embarrassed. I've been in a meeting at one time and a university in that country was presenting some information they had in the country of disease. And the set of information they presented was more than what the CVO of the country presented. Then the WOHA team in that meeting raised hand and they were joking with the CVO, say, is this university not in your country? Why is the university having more data than the... So you can see how embarrassed the CVO of that country became. And so we really need to be intentional about our contribution to our national system. It shouldn't be about personality. It should be about our nationality. And we all need to be co-contributor to the success of our country in terms of data harmonization. That would be my view. Thank you.
All right. Thank you so much, Prof. Although time is fast spent, so in 5 minutes time, we should be out of this place. So let me just ask a final question around. I'll start with Dr. Zainab, and then you will also provide your final remark. You know, I hate to, I'm not sure if the question has been satisfactorily answered. You know, all in me wants to say who is to blame, right? Us that are not doing our own bit, or because these things are frameworks, right? There's no punishment for not doing it. So everything is just okay. Doc,
Yeah,
sorry,
it's back.
I went.
Sorry, I'm
on a
back
little
on.
bit. Yes. So
I thought it was me.
no, it was me. I don't want to do the blame game, really, right? But it looks like both parties are not doing their bit. So I know you've said we put the work on ourselves, but how much can individuals do? how can we get our policy people, the people in the ministry? Can we get them to work better, or we should just leave them alone?
So, from my own thoughts, who is to blame? Everyone is to blame. Honestly, there is no sugarcoating. Everyone is to blame. If we do our individual parts and the ministries do not do their own individual parts, so there is no pointing fingers. We like to go for advocacy visits, but are we even advocating within ourselves? Before we go out, we have to fix our own house. It's not about advocacy visit to this, let's do this together with this organization. Let's start within, even between the state, the LGA and the state, even between the ward level and the LGA level. Let's start up something. It doesn't have to be big and large, but let's start something. Policy would grow when there's something tangible at the state level. For instance, personally, when I'm even looking for data, I don't look for data at the national level. I go to the state level to get my data. If a lot of papers are coming from the state level, one day someone will say, this data that is being, this paper that is being published, why is it always from Kano? I have a reason for doing that. It's not just, because I just want to work with Kano State. It's about starting something from where I can. But as you said, if I do as much as I can, but the upper level does not do its part, who is to blame? We're still both to blame. So for instance, when you're looking for knowledge and you go to a classroom setting and you're being taught about basic epidemiology of person, place, and time, and you just leave it at that, and you are being assigned a mentor, for instance, mentor-mentee relationship, and you start saying, my mentor is not reaching out. My mentee is not. You push. You keep on pushing. You don't stop pushing. You push to when you're near satisfaction. So if we begin to advocate and fix our own jollof rice before we start serving it to other people, and that's why initially I said that is why we are not leading the One Health approach, because we do not have our house together. I'm sorry to see, but it's very, very fragmented at the ward level, at the LGA level, at the state, and at the national at some point. But if we have this synergy and people, we do not wash our dirty linen outside. We have to come back together, sit together, forget other differences. It's not about, this state doesn't like this state, I don't like this person. We all have a common goal. So let's just sit together and let's try to achieve it. Thank you, and over.
I hope that time comes really very soon. You know, when Dr. Sanusi said the data were good up until 1995, and they asked themselves, so what happened in 1995? Oh, I wish you didn't say this publicly, right? He said the vets took over. So maybe university also, I think it's just, this problem is like an octopus. It has 8 legs. We have 1 leg in the quality of training, we have 1 leg in the policy, we have 1 leg in private sector, we have 1 leg in individual cultures. And so coming together to address this and having strong leadership will be the very basis. Dr. Shittu, I see you're raising up your hand, so you could say what you want. But I have one question also in addition to what you want to say. So the best we can do in this meeting, so that at least this meeting becomes very progressive, is to tell the individual in this place that if it's not collective, at least do your own isolated one and keeping it. Some of us were like, I'll be 42. Do I have data, 10 years? Personally, myself. If Mohammed won't go to the mountain, at least let the mountain also go to Mohammed. If the policy people won't, I think they're doing their bit, really. So there's no need to publicly talk about things that I don't know so much about. But I don't want, focusing on them will be a waste of time, really. What can I do? So what will be your final word in terms of encouraging people to have personal data and not necessarily just pushing the blame game? Go ahead, Doctor.
Yeah, I think the solution, I can say that the solution or the problem is complex. First of all, we need to identify the problem first. You cannot fight something if you don't understand it. So we need to identify the problem first. I always give example uh, with the developed world where the practice is the best. And so they have a centralized system. The DEFRA, Department for Environment, Food and Rural Affairs, which is like the Nigerian Ministry of Livestock, they keep all the data related to animal health. And then, so they have a special section for data scientists. These are people that are employed to do only that job, and they are being paid. And if you want data regarding slaughter statistics, right, and maybe confirmed cases of fasciolasis in cows, you ask the Meat Standard Agency in the UK. They collect and assemble all the data from all the slaughterhouses in Great Britain. So that is a centralized system. And then I think there is attitudinal change. What I mean by attitudinal change is people, they are interested in something within a short time. We can start doing something now. We may not be the ones to benefit from it. It may be the next generation in the next 30 or 50 years. But it is very sad and very unfortunate that even uh, the employers themselves within the animal health sector doing something that is inappropriate. And I'm sorry to say that it was during a surveillance program collecting samples from animals from livestock around the border between the Sokoto and the Niger Republic, and where people, when they collect sample from cow number one, they dispense it in 4 different bottles and label it as samples collected from 4 different cows. So if samples were collected from 100 cows, it will be as we collected samples from 400 cows. And these are professionals that are doing it. So because we don't take it seriously, we don't know the importance of data and the type of information that data can give us, and we can use that information to provide a solution and to improve the quality of our livestock and humans as well. So that is on the aspect of attitudinal change, honestly. It's a bitter truth. I'm sorry. Thank you.
Thank you, Dr. Shittu. But those are some of the things. That's why I said this problem is like an octopus. If you hold one leg, just understand that there's 7 other legs that can also hold you to ransom.
Yeah.
So just imagine you are paid to go and collect sample, and you collected sample from one and you spread it inside 4 test tubes.
Yeah.
So at the end of the day, it's just very difficult to say that this person is wrong because, and this on a lighter note. Sometimes I misbehave, I'm married, I misbehave, and you will not talk because maybe your spouse misbehave, you will not talk because by the time you talk about our own, you talk about your own, and then the fight becomes very intense. So if you have your own and then she has her own, both of you will just keep quiet and keep looking at each other. We have a problem. The policy people are not up to date. The universities are not really enforcing that the students that are coming out should take data seriously. The country in itself. I was in a meeting, and finally, before Prof comes up, and the person said he has been submitting. But the day he stopped submitting was the day he went to visit his own DVS, and he saw his data that he was submitting, water poured on the file, and they left it on the floor. So just look at that. He said when he went to the DVS and saw that the file of the painstaking thing he does every month to send to the DVS, water has poured on it, the file is left on the floor. So even God will not punish you if you stop sending, because you just get extremely very discouraged. Prof, you have to use your professorial I would not want to use the word anointing, but So what's going to be the way forward and what's your final words? Because I think we wanted data, but the data is confusing us at this moment.
Okay. Thank you very much. Just briefly, as a way to round off, questions on the sidebar, which was put in the chat. Somebody said, "Oh, can the VCN lead this process?" I said, "No, it's not the VCN. It should be the mandate of the CVON." And it is good for all of us to have a data repository, one single major data repository, which we can all be co-contributor to. And this can be with the CVON. And as I've just been joked about now, the government also need to show responsibility to these data that are collected and show commitment to it, and also make it user-friendly, make it interactive, make it something that people can relate to. For example, I should be able to get to NADI's platform now and check the data there and view disease near me and know exactly where a particular disease is in the area. So with that, I will know that, okay, if I submit data, I know this is the likely feedback I can get from this data. It encouraged me to want to do more. Secondly, we also asked, we were also chatting on the side that, is it possible then for us to also get the VCN to begin to tie some CBD point, continuous professional development point, to data that you submitted? If in the year you are a researcher in avian influenza and you've done work the whole year, and you didn't submit any data from what you've done, maybe you lose 5 CBD points. But if you contribute those data and it enrich the national system, you get maybe an additional 5 CBD points from what you get. And it is here we don't value those CPD points. In most other countries that I know, the CPD point, people hold this so dear that they want to have it every year. So if we begin to do such thing, maybe it's the VCN can then work with the CVON office, and then the state, the DVSs at different states, we should encourage them to also contribute to this. The private sector should contribute to the state DVS so that they can contribute to the national. The local government should also become co-contributor. The university system, our research system. Indeed, if we look at the volume of research and work done in Nigeria, we should be the data richest country in Africa. Yeah. Unfortunately, that's not the system at the moment. So please, it is something that goes to all of us. We need this attitudinal change, and all of us need to be co-contributor to the success of our country. Thank you.
Amazing, Prof. Amazing, Prof. I see Professor Kudi also on the call. Prof, we want to say something briefly, and then we can wrap this up. And I want to thank everybody who's joined, Professor. I'm trying to, Prof is also a member of the Veterinary Council Board, and one of the foremost and respected people we have in the profession. He has been on this call for a while. I think since beginning, really. I've seen his name since. I'm trying to unmute him, but again, as a way of summarizing, first of all, is to thank all our hub experts. The biggest takeaway for every one of us in this call is that, well, and that came really very strongly from Dr. Zainab. If you're pointing one finger, 4 or 3, or as the case may be, might be pointing towards you. So let it start from you. Don't worry about the country. There was and I like that lesson. There was somebody who drew a scattered map and didn't know the answer to the map. But when the person was putting together, the person turned the map upside down and saw a man and was able at least recognize a man, put the man together. And by the time the person's opened the map had fixed itself. The problem is complex if you want to fix the country. It could be simpler if you're fixing yourself. And so the call to be data-driven, the title is data-driven professional, not data-driven country. It's just very difficult to do data-driven country in this type of meetings. But if you're a data-driven professional, you understand why. Maybe one day you'll be CVO, maybe one day you'll be minister. But if you've not built the culture, it is almost impossible that you will probably be one of those DVSs that pours water on people's data and put the file on the floor. You will not be able to create an attitude you didn't build over time, overnight. Right. So I think the biggest call is that hey, start from you. Are you a practitioner? Is your data organized? Are you a farmer? Is your data organized? If somebody wakes you up at time T, you're a paraprofessional, is your data organized? And then maybe on more of a business angle, I want you to try. So I want you to try. You can always reach us. We dropped like the link to an application. I think instead of sitting down and doing nothing, right? FarmerLab wants to now start aggregating the data of farmers across the country with the hope of providing them access to quick vaccines, which is part of our core mandate, ensuring that we enable easy access to animal health. So we've given ourselves a goal of at least registering 1 million farmers. Livestock, you have goats, you have sheep, you have cattle, be on the platform. We are also going to be recruiting volunteers to help us populate the data. And what we owe everybody who registers is that at least vaccine availability will be able to tell you, and you will also be able to report if there's anything wrong with your farm that you need the help of an animal health professionals, because we are equally onboarding animal health professionals. We're able to link a contact that is closest to you. Hopefully, if we're doing this, we should be able to also provide the government a few supports here and there. But real data, the real progress begins from all of us. And I want to use this moment to thank Professor Fasina. Thank you so much within a short notice for coming, and want to thank Dr. Aminu Shittu, your platform of 9,000 professionals. That's data. Like that's real data. So you have lived, you have lived your talk. Thank you so much for being that effective. And then to Dr. Zainab, I hold the view that Dr. Zainab should talk more in the public space. You're very, I will not use the word modely, but your very thoughtful conversation can really drive change. So I want to thank you also for sparing your time. I saw that you were in a vehicle. It means that today is a very tight day for you, but you spared out the time to come. And I think for whatever it is worth, most of us are leaving this meeting being data driven. We understand why, and we know that the data that we seek begins from every one of us. To my team, FarmerLab team, the Impact team, and the media team, thank you for making this a reality. And to everybody who joined, your certificate will be sent to you. We have collected your data, so we have those data. That certificate will be sent to you via email. Your soft copy of your certificate will be sent to you within the next 1 week. I want to say thank you, and then, of course, compliment of the season to every one of us, and have a wonderful afternoon. Good afternoon.
Thank you so much.
Thank you too. Thank you.
All right, thank you, everyone. Thank you, Dr. Femi.
Thank you,
Thank
Dr.
you,
Zainab.
Dr.
Thank you, Prof.
Prof.
Thank you, Dr. Sheila.
Thank you very much,
Professor.
everyone.
Thank you, everyone.
Yes, thank you, Doctor.
Bye.
Thank you so much.
Thank you very much. Thank you, everyone. Thank you, Professor.